Our first chance is our best chance to cure patients with advanced ovarian cancer, and most cancers in general, but definitely with advanced ovarian cancer. Our first chance is our best chance to cure them. Studies on prognostic factors have shown that there are various things that will contribute to how well a patient does with advanced ovarian cancer. Things like how old she is when she gets her first treatment, whether or not she has ascites, how much tumor she has when she first presents, what stage she is, whether that patient is sensitive to chemotherapy or not, even the tumor grade, how much cancer is left over at the end of that very first surgical procedure is the only prognostic factor that we have any control over. For years, the notion of taking somebody to the operating room and debulking all the big, bulky tumors and leaving behind microscopic cancer cells has been the way we've approached advanced ovarian cancer. As OBGYN trained doctors, we're used to operating in the pelvis. So if the cancer escaped the pelvis and went to the liver, or the spleen, the pancreas, the diaphragm, even though we trained to do gynecologic cancer surgery, we weren't specifically trained to operate in those areas. Back in around 2001, we as a service here at Memorial Sloan Kettering Cancer Center decided to consult or ask our upper abdominal surgeons to help us to clear the disease in the upper abdomen. If it meant taking out a portion of the liver, taking out a piece of the diaphragm, taking out the spleen, whatever we needed to do to get the end result of very, very minimal, if any, residual cancer. By using this change in the surgical paradigm, by us operating on any area in the abdomen where the cancer had spread to, we're able to improve our good result, or optimal debulking rate, from 40 to 50% to about 80%. And that improvement in surgical removal of cancer at that first surgery has translated, because of the effectiveness of the chemotherapy that's given subsequently, has translated into improved what's called progression-free survival, or in other words, time to recurrence, and bottom line, overall survival. So with this more comprehensive, proactive surgical approach, our patients are more frequently put into remission, the remissions last longer, and the bottom line, our patients survive longer and are more often cured than with a more standard surgical approach.